Well, good morning and welcome to Florida Healthcare Association's webinar series on the patient-driven payment model. I'm Melanie Motiska, Quality Improvement and Education Manager for the Florida Healthcare Association. Before we begin, we'd like to thank our title sponsor and executive sponsor, Medline Industries, for their support and sponsorship. From their innovative neurogym therapy line, their workforce software partnership with OnShift, and their resident assessment real-time software, Medline has what you need to not only easily transition, but also succeed under the PDPM system. Please take a moment after the webinar to view the video on the FHCA website highlighting the neurogym therapy line, or contact your local Medline representative for more information. Thank you, Medline Industries, for sponsoring today's program. I'd like to get some housekeeping out of the way so we can get started with today's great program. Due to the large number of participants, all our attendees are muted, and we encourage you to use the computer audio rather than a telephone to maintain sound quality for today's presentation. We encourage you to submit questions throughout the presentation by typing your questions into the question box on your control panel. The slide you see now shows how to submit a question using the question box. You may also email me directly with your questions at mmotiska@fhca.org. We will compile a Q&A document and make it available for everyone through FHCA's various communications channels. There are additional handouts available on your control panel. So if you bring that tab down, you'll be able to see the handouts for today. This webinar is being recorded and an online archive will be available in the members only section of the FHCA website. If you have a colleague who was unable to join us today, please encourage them to view that recorded webinar. It should be available in just the next few days. And now I'd like to introduce today's speaker. Robin Bleier is president of RB Health Partners, Inc., a clinical risk, Medicare, and operations consultancy firm. A featured state and national presenter, Ms. Bleier is a special topics advisor to the FHCA Quality Cabinet and a vested long-term advocate through her volunteerism and affiliation with numerous state and national professional committees. Ms. Bleier's firm, RB Health Partners, provides consulting services to FHCA Quality Affairs Department. Thank you for presenting today. Let's get started. Today's presentation is titled PDPM Bootcamp Basic Training. And with that, I'd like to turn it over to our presenter, Robin Bleier.
Good morning, everybody, and thank you, Melanie. I appreciate it, and happy Friday to all. I'm going to see if we've changed over and I can advance the slides. So, Miss Melanie, I think I might need a little cursor help, and then we'll be good.
Okay. All right, it's in place.
All right, thank you so much. So you'll see on this slide here that it says CMS released some PDPM guidance. They did it last night. So I have not reviewed that in terms of this presentation because this was revised March 11th. I have started to read it since Melanie and I talked about it this morning just to see if there was any conflicts, and so far I haven't come up with any. But as we know, PDPM is official October 1st. So I will not be surprised, as I'm sure you won't, that things will continue to change and morph as we move forward. If I find any direct conflicts with the information in this PowerPoint, I'll submit it to Melanie so that she can give it to you. And as you know, this is a webinar series, so we will continue to update as information from CMS becomes available. So I just wanted to note that. Okay, Ms. Melanie, I need you to do your cursor so I can find the place. Okay, so objectives for today's brief 1-hour program is to make sure everyone on the phone is able to identify the 6 components that the payments are going to be based off of, to be able to review each of the per diem rates in the calculation process, not how to do the actual calculation today, to be able to review the per diem rate type, how it tapers in the course of the resident's stay, and then to identify how the MDS schedule is going to be affected under the PDPM process. This information that we've included, we've also, besides using information from CMS, of course, we've used information from ANAC. So let's get started. We start off with that PDPM uses clinical conditions to determine the resident's therapy payment group rather than the amount of therapy that's been provided. That's probably the most instrumental change. I was talking to one real experienced provider the other day, and he and I were agreeing that PDPM has a lot of elements of PPS, or what were the initial elements. So back at the time when PPS was being released, I went to and I continue to go to the trainings that Baltimore CMS offers related to new changes and MDSs and payments and so forth. And the interesting thing is when you go to those trainings, you don't really necessarily learn how to do the change, but the most important part of that education is about why. And I mention that now because a lot of the whys that were discussed as it related to PDPM actually were a lot of the whys that I remember being discussed at PPS, to include resident center, looking at the person individually. And so as we move forward, it's going to make us change things. For instance, how we do our weekly pre-billing check meeting. It'll probably go back to more of a case management utilization review meeting. So there's going to be things like that that will pop up as we go through this today. So PDPM is composed of 5 case mix adjusted payment components. All of them but one are case mix. Obviously, non-case mix one is going to deal with room and board and things like that. But PT, OT, ST, nursing, and non-therapy ancillary services are all case mix. Only nursing and speech therapy will not have a tapering off of the rate, which we'll talk about later on, which means PT and OT will, as will the NTAS. So when we look at that tapering, we're having to think about that process and how we're going to plan on it. Tapering begins on ATS after the 3rd day, whereas it's after the 20th day for PT and OT. Speech and nursing, again, are going to remain consistent during the entire time that the person is using their Medicare Part A benefits. And so obviously some thoughts and planning are going on that. I had one provider talk to me recently about the fact that OT and ST has some lap over, and so they were wondering that, you know, based on their staffing and the available numbers of STs, if they had a qualified OT who did swallowing or dementia care, how would that impact it? And if the person was doing a service that speech therapy could do, would it still have to taper? And thus far, the information that's available from CMS is yes. Well, then the provider said to me, well, there's a lot less STs available. And I said, yes. So there's going to have to be a lot of planning and reconsiderations just to ponder. The nursing skill categories are going to reduce. So you'll see on the slide there were 43, or there are 43 right now, and it will collapse down to 25. And that's important to note. In addition, the ADL index will be based on the scoring from Section GG effective October 1st, not Section G, which is what we're currently used to in PPS. The physical therapy and the occupational therapy are going to use the same scoring methodology that we're using in nursing. So that'll be interesting, and it's all going to be based on Section GG. You'll remember now that the ADL index score, the higher the number that you got out of Section G, that meant the more help that a resident needed, and that increased your rate under PPS currently. However, it'll be the opposite. Section GG is the lower the number. So there'll be some new things to learn and or rehash, as Section GG already exists, but the conception is going to change quite a bit. The speech language pathology treatment has a different scoring method, and we're going to go into that a little bit more in detail. You know, it's funny, we use physical therapy assistants and occupational therapy assistants. I was reviewing the Speech Therapy Practice Act the other day, wondering why we're, you know, in PDPM, will we start to be using some speech therapy assistants? Right now, you can find most of them working in the school system, typically working with developmentally disabled kids or those that have cognitive issues. So it'll be interesting to see if we'll be reintroducing speech therapy assistants into long-term care, because they haven't been there for a very long time, pretty much since we went to PPS. All residents will be classified into a therapy classification as well, whether they're on caseload or not. So we've always talked about in PPS, and even before PPS, we always talked about the concept that a resident has to have a nursing skill to be a rehab patient or to be a skilled care patient. And so not everyone is really focused on that, but it's always been that way. And the reason why is that they have to have a nursing skill is because if therapy stepped away, how would they still be skilled? And it would have to be nursing. The only exception to that has been if they had therapy ordered for 7 days a week and it was being given 7 days a week. Otherwise, they actually have to have a nursing skill. And currently right now, in your weekly review meetings, whether you call it pre-check, triple check, quad check, everyone calls it something else. But when you do that, you should be reviewing the nursing skill. In preparation for PDPM, I certainly hope that that's happening. But we should also be reviewing the therapy skill as well. PDPM also uses the depression scale and restorative services to further adjust your case mix index. Now, this exists in PPS, but a little bit differently. If a resident was skilled and they weren't getting therapy and they were being covered under nursing, then their indicators of mood state, which you get out of Section D off of the PHQ-9, would count. And if you think about it, if you go back today and look at your rate sheets for your current rug rates, if you looked at the difference between an HE1 and an HE2, depending on a few factors, you might be anywhere between $40 and $60 a day difference typically. That's a lot of money. And the difference between an HE1 and an HE2 is that a person does or does not have indicators of mood state disorder. And again, that comes from the actual interview that's done on the MDS in Section D. The restorative nursing services to further indicate that is also very important. I would expect that particularly on a long-term care patient or those that have neurological deficits that go into the hospital, come out of the hospital, and are on skilled care that are also getting therapy, that the longer stay person is going to have a longer length of stay, obviously, in their therapy, particularly because you might be working to develop muscle memory if there's cognitive loss. And that would be an appropriate person where they would then hand off to restorative care. Well, we could have been doing that already. Right now, we have rehab low and reduced physical function in PPS. Reduced physical function in PPS, I've never seen that be economically worthwhile to document, just because by the time you're done with adding on your per diems for your pharmacy costs and lab and x-ray and whatnot, that it would become a loss. It wouldn't become a gain. Whereas rehab low typically isn't done too often as well for a variety of reasons, because it hasn't been managed to be economically feasible. But one of the issues with that is you have to have an active and a very functional restorative program. And many facilities struggle with that, or you have a restorative program and restorative aids, and then there's a call out and that person's asked to fill on the call out. And during the first week of the month, they tend to be getting waits for people and things like that. So now would be the time to really look at your restorative nursing program. And as you know, FHCA does have a multitude of education going on to help everyone be successful in PDPM, from ICD-10 to include restorative training. In that training, you will be given a restorative program from my company that you're welcome to use. If you make it better, I always ask everyone to send back in your suggestions so that we can help other people do as well. But you do have to have a documentation system. It will have to be 6 out of the last 7 days in a week. Each restorative therapy will have to be 15 or more minutes as documented, which means the program has to do that, and you'll see a place for minutes on the program that you'll be getting if you or your staff go to that restorative program, because all that will have to be present. So many centers tell me that they're struggling to have a successful restorative program, and we will discuss techniques and methods to include that and improve that in your organizations at that training. The non-therapy ancillary services, which is either abbreviated as NTA or NTAS, and I've done it both ways because we've seen it both ways in the CMS literature, so I want to make sure that I'm consistent, are used to adjust the case mix overall scoring, as well as consist of a score for the number of comorbidities that are going to be coded on the MDS. Now, there are a total of 50 comorbidities that are going to be considered for that. We'll definitely talk about that today, but in this brief hour, not too detailed. However, that will be greatly covered during the ICD-10 training. PT and OT components that are important, again, they're calculated in the same manner, but they're going to be paid differently based on the separate case mix indices. The drivers of the components are going to be the primary reason for the skilled stay, utilizing the diagnosis codes in conjunction with specified surgical procedures to classify residents into one of the 4 PT and OT new clinical categories. So those are going to be new MDS questions, and they're going to be J2100 to J5000, which I have later on in your slide. And it's also going to look at the functional score. So the selection of the primary reason for skilled stay is going to be important. So this code will be entered into MDS item IO200B, and if IO220 is coded as a reason, it'll be in 1 through 13, and those are going to be new categories. Now, ANAC is having their updated education, and I'm sure you or some people you know in your organization are going to that training, and that's next week, and that's the same with mine. So when the advanced MDS class is taught by Nathan Shaw for Florida Healthcare Association, it will be after he's attended that advanced training as well, as I'm sure some of your staff have been. The CMS update on November 19th talked about the new items that are going to be for October 1st effective date. And as you all know, sometimes CMS will say this is what they're going to update, and then there's some tweaks to that. So we'll continue to monitor that very closely. The selection of the primary skill for skilled stay is, again, very important. It's going to further delineate and may be made into a surgical category based on the specific procedure that occurred when the person was in the hospital. Now, having said that, you have to make sure that you have a system in place today to make sure that you're getting those surgical H&Ps, history and physicals, in good time frame compliance when you're admitting the person. Depending on different parts of the state, I hear various individuals telling me how successful they have or have not been in their ability to obtain that information from the hospital. So as you can see, I referenced J2100 to J5000 a few moments ago with regard to where the surgical procedure category is going to go. I mention that now because you cannot code anything on the MDS that cannot be found in the residence record during the assessment reference date period. The exception to that would be interview information. So when you interview a patient, that will be coded on the MDS based on what the resident interview includes. So if you have knowledge that there was surgical history, but you don't have the information from the hospital, and you haven't added a diagnosis with the primary care physician of that surgical post-procedure, then you won't be able to code that, and that will be problematic. So you're going to have to review those systems that you have in place right now to do that so that you can feel that you're more on the mark at that time. You'll find all this will be coded in Section I on the MDS. So here's a review of the new currently known MDS items. And I didn't include a new MDS format because I believe that there's a little tweak that's in the process of going on, but we will continue to add information like that to the Florida Healthcare website so you have that. And you can see J2100 starts with a recent surgery requiring an active SNF care. And it goes on to include quite a few more that I'm not going to read to you in our hour today. But all of those will be listed again in Section J where we add that. Now for therapy, PT and OT components, we have the selection of the primary reason for skilled stay. And so we said earlier that we have 4 major clinical categories, and that's going to include medical management, non-orthopedic surgery, other orthopedic, and then major joint replacement or spinal surgery. So those are the 4 set components. So on this slide, you can see the major joint replacement or spinal surgery. You'll see on the far left-hand side an example with the ICD-10 code, and then you'll see the description that's appropriate to that code. It is really important that people either use their manuals when they code or an electronic system that actually goes through the manual process for specificity. When you're coding, I know a lot of people want to just Google a code or they want to Google something. You'll not get your right codes if you don't actually follow the process. Now, I'm sure your MDS software company has embedded the more popular codes, and that's good, but it's really important to go through the process. You want to make sure your facility has at least one of the current ICD-10 coding manuals, and if you need a recommendation on one, please let us know and I'll be glad to send you the one that we use, which we use all those manuals that we get through AHIMA, the Professional Association for Coding. So I'll be more than happy to help you with that. But if you were looking at the code, so PT and OT codes, you'll see major joint replacement or spinal surgery, and then it'll give you the primary diagnosis clinical category because they have to correspond. So you'll see, for instance, spinal surgery would go under major joint replacement or spinal surgery. Other orthopedic might be a major joint replacement or spinal surgery. If you look at non-orthopedic surgery and acute neurological, then you'll see that reference. And then major medical management starts with acute infections, cardiovascular, coagulants, pulmonary cancer, and other medical management. Now, it's interesting about the acute infections. As you know, CMS requires that you're a designated infection preventionist who in November 28th of 2019, it'll have to be their, quote, primary job. And you know, PBJ defines primary in their regulations. And it's interesting because we know that infection is the #1 citation nationwide. So it's interesting as it relates to therapy with major medical management and acute infections, because I've been noticing more and more citations in infection prevention and control, 880 FTAG 880, that includes the therapy gym, more than I've seen in a while, talking about the process and procedure between cleaning your mats between patients, changing of linen, the management of hydroculators if you still use it. So it's interesting how some things seem to have cross-reference a tad. Now there's 16 PT and OT case mix groups. And so just as an overview of the slide, you'll see that you have your clinical category, functional score, the PT case mix group, and then ultimately that'll span out to your case mix index or your CMI. So, and it uses the same 4 categories as we just talked about a moment ago. Now the functional score is going to come from section GG. And that'll be calculated to calculate the PT and OT functional score. So it's the same 4 late loss ADLs that you were used to, plus the 2 early loss ADLs that were added. So you've got 2 bed mobility items, 3 transfer items, 1 is in eating, 1 is toileting, 1 is oral hygiene, and 2 are walking. So if, as a reminder, and this is not new, section GG uses a 6-point scale. And it uses number 3 means that it wasn't not attempted code, whereas in section G, not attempted is 8. So to calculate a 0 to 4 scale for the functional purposes, we would use that section GG. So a little example here, PT and OT functional score construction. And you'll see on the far left-hand side, look at the responses, setup assistance, independent, for instance, and you'll see the score. And remember, more care is needed with the lower score, as opposed to in section G, which is completely converse of that. So if you look over on this next slide, which talks about section GG items included in the PT and OT functional measures, you'll see on the far left-hand side, that's the question number from the MDS. And then in the middle, you'll see what the actual area is. So this item section, which the first one, for instance, is self-care for eating. And then you'll see the score, and you'll see what the opportunities for the score are, 0 to 4. So please note, though, on bed mobility, transferring, walking, those items are averages or rounded to determine the functional score when they do that calculation. Now, if you go back to the therapy case mix classification groups, remember we said there were 4 clinical categories, so they go in the same order: major joint replacement or spinal surgery, other orthopedic, and the next slide will have the last 2. You'll see that it combines the section GG functional score, and then it'll look at the PT-OT case mix grouping, look at the PT case mix index, and then it'll look at the OT case mix index, and that'll be helping you to get your final scoring on that. Now, speech is a different animal. There are 5 characteristics that will impact the speech therapy component. It's going to look at swallowing, mechanically altered diet, cognitive impairment, speech-related comorbidities, and acute neurological or non-neurological deficits. So the interesting thing about this is, again, remember, speech is the therapy discipline that will not go down 2% every 7 days, like PT and OT will. Which starts on day 20, the NTAS, which is going to go down 2% starting after day 3. Remember that. So speech therapy and nursing is never going to do that. When you look at those 5 characteristics, I'm sure that you could think back to times that, based on the skill set of your occupational therapists in your building, that occupational therapy could have treated several of these items just as easily as speech therapy could have treated them. So I mentioned that comment earlier. I'm not sure how you guys do that in your buildings, and you want to look at that. I've had a couple buildings that say we very rarely have speech therapy because our OT does a lot of that. So you just want to kind of give that some thought. Speech therapy case mix component is going to use diagnosis codes to classify the residents into the neurological and non-neurological clinical categories. It's then going to utilize the codes to capture speech-related comorbidities, looking at things like oral cancer, speech therapy deficits. It's also going to look at the following comorbidities that are going to be pulled again from section I. Now, active diagnoses is a process in section I of the MDS manual. And if you want to jot down page MDS manual, chapter 3, page I-6, that's where the definition of active diagnosis is. It's in a little text box in the far right-hand side. And we encourage you to do that because we want to make sure that it's an active diagnosis. When I look at people's face sheets and other locations where they have diagnoses, there's a lot of really non-active diagnoses. And it's interesting, how long a person's had a condition isn't necessarily the indicator of whether or not something's going to be an active diagnosis. You could have a patient in your building that maybe they had a motor vehicle accident 6 months ago, and they got a closed head injury, and when they had that, they had a seizure, and when they had a seizure, they had a CVA. But once they've had therapy and they've returned to their prior level, they're probably after 60 days, because it's a 60 days where the physician documented diagnosis and condition that you'll read about on page I-6. So you could have very easily that 6 months later that they are resolved and that they are not at risk for another CVA. There's no active nursing function or skill to monitor the patient. We're not taking blood pressures. We're not doing anything to evaluate their potential of getting another CVA. They didn't have a blood clot. They're not on blood thinners. It's very possible that that will then not be an active diagnosis. Correspondingly, you could have someone that had a massive CVA 20 years ago, but they had it because they had malignant hypertension, which meant they had uncontrolled hypertension. And in that person's situation, they may be on antihypertensive medications. They're getting daily blood pressures, perhaps before they get that. If they have, severe headaches, we're monitoring their blood pressures and other things that your nursing staff is doing. And therefore, they might have for the rest of their life an active diagnosis. So time in and of itself does not dictate whether or not a diagnosis is active or not. And we encourage you to evaluate that in the process. It used to be, before we went to electronic health records, a lot of people used a cumulative diagnosis sheet. And when we went to the electronic health record, I noticed that that went away for a lot of people. I encourage people to consider whether or not a cumulative diagnosis sheet will help them. But definitely, I'm sure your therapy, your radiation therapy, your X-ray therapy, your lab therapy companies will be very happy when you get your active diagnoses updated. Now, we're also going to have comorbidities that are again going to be pulled from active conditions, and you'll find them on I-8000, and it'll look at things like laryngeal cancer, apraxia, dysphagia, ALS, oral cancers, and speech and language deficits. So again, anything that's coded on the MDS should be found in the patient's clinical record during the assessment reference date, or ARD period. Typically, that's a 7-day period. Sometimes it's a little longer. PHQ-9 Section D happens to be 14 days. Pain is, for instance, 5 days. So there's some variables. But other than a resident interview, we should not be coding anything on an MDS that cannot be found in the patient's record. So if we know something should have been in the patient's record, then we need to get it there, which is, again, why you want to evaluate how effective you are at getting your hospital H&Ps for discharge, emergency room, and surgery, because that'll be very important for PDPM. So here's another view at the speech therapy related comorbidities that we just read, so I won't read that to you. And then if we wanted to look at the overall speech component, we'd see the condition. The speech and language deficit is the condition. You'd see the correspondingly ICD-10 code that would then be more applicable related to the description that you'll find on the far right-hand side. So let's go to the middle and say speech and language, and we'll say code 169.921, dysphagia following unspecified cerebral vascular disease, a very common one that we'll see. Now, there are some additional factors that are utilized to adjust the case mix index calculation. Mechanically altered diet. Now, I mentioned that because, A, because it's required, but B, a lot of people have worked diligently in person-centered care to normalize some of the diets that your residents have when they eat. And unfortunately, that's a little bit of a thing to deal with, because we really need to make sure that our mechanically altered diets are recognized as diet orders, not preferences. A lot of people will write things as preferences now. It's also kind of a regulatory thing. So we want to make sure if it's a mechanically altered diet that there's a physician prescription order to say that it's a mechanically altered diet, and then that should be documented in K0510CT on the MDS. It should be found in the record during the ARD period, and it should be coded there accordingly. If you coded that, or if you went to go bill for a mechanically altered diet, but it wasn't actually on the MDS, that would be a problem. Same thing for swallowing disorder and cognitive impairment. Of course, the cognitive impairment comes from Section C, which looks at the BIMS, the brief interview for mental status. Having said that, CMS's expectation is that in addition to the BIMS, or the brief interview for mental status, that the speech therapist or treating therapist will be using other diagnostic methodologies to evaluate cognition, such as the Allen Cognitive. It could be the Global Deterioration Scale, the Mini Mental, etc. So you have to look and see what types of training you're going to be using in your building and testing to do that. Recently, I helped a facility out of Mississippi that had a ZPIC audit, and they had coded they used the BIMS, speech therapy used, but yet they were providing cognitive impairment training, but they didn't do any other testing, and I would tell you that that was not a very successful outcome for them. Now, the cognitive functional score is where CMS is proposing the blending of the BIMS and the CPS to get that score, so it's pretty self-explanatory, and it's still in proposal state. 12 speech therapy case mix groups that are going to be present. So you'll see on the far left-hand side, presence of acute neurological condition or speech-related comorbidity or cognitive impairment. And so it will be either none, it could be any one, or it could be two, or it could be all three. And that's what they're looking at for there. Then the next column says mechanically altered diet or swallowing. Yeah, so it's either going to be neither, either, or both. And then we're going to look at the speech case mix grouping, and then we'll get our CMI. So nursing case mix classification, again, we went from 43 down to 25. There'll be a modified version of the RUG-4 nursing categories, and nursing will use section GG to capture that nursing functional score, just like OT and PT is going to use section GG. We'll use same functional scoring then, like I mentioned, as still the 0 to 4 point scale and the average bed mobility and transfers. So here's a little view of that. If we look at the section GG items, so we'll look at that. Nursing functional score construction. So again, reminder, the lower the score, the more dependent the person is. The complete opposite. Bed mobility, transfer, and items average are going to be rounded just like they were in the PT and OT slide that we spoke about. This is a little hard to see slide, so it's good if you have it on your computer and you can enlarge it. This is just for the nursing case mix classification. It said see handout. This is the handout, and that is extensive services. And then you'll see it'll go over to it'll talk about the condition and the services, and then it'll look over of whether or not the condition of the services were present, and then where it is in section GG, and then it'll give you the PDPM RUG. Let me do a little reminder. When you look at extensive services, it talks about isolation. That isolation has not changed from what PPS had proposed. It's isolation based on CDC guidelines or APEC guidelines. That is clearly articulated in Chapter 6 of the MDS manual. That has not changed. It's my recommendation if you're going to bill for that highest category, because as you know, currently in PPS, there's a significant variance in that means that I would print that off from the CDC website at that time and put it in the financial file. If the doctor orders or prescribes the patient to be on isolation, that's fine. You can do it, and you should do it if the doctor orders it. However, if it does not meet CDC or APEC guidelines, then CMS will not recognize it. And if you bill for it and then have an audit later, you will have to give it back. So I just wanted to point that out. You'll see on the nursing case mix classification, it's going to then take that nursing PDPM RUG that we got on the sheet prior, add in the functional score, and then you'll see your corresponding case mix index. Now, I think everyone probably remembers about the HIV/AIDS add-on, and if you were coding it, it's B20 on your claim, and there's a process to code it on your claim. I'm sure if you need any help with that, Julianne Kemmons, who I believe is scheduled for the next one or the two PDPM series, will be able to talk about more about that with you. But under the HIPAA Privacy Act, there's a process in making sure that we bill B20 correctly, and we certainly want to do that. The facility will gain 18% increase in the nursing component for the care and costs related to taking care of someone that has a diagnosis of HIV/AIDS. Now, to look at the extensive services, we talk about the trach and the vent, and just like the isolation, CMS has some specificity to that. There are people that use BiPAP machines, but they're not being used as a vent, and we want to make sure that they're not being coded as if they're being used by event. Again, Chapter 6 of the MDS manual gives some pretty clear discussion on that. So let's assume that it's the trach and/or vent is being used. We have that as an extensive services 3, and you'll see the indice to the right of that. Special care high. So we have our qualifiers related to that. So same ones: comatose, septicemia, diabetes with daily insulin injection and/or order changes 2 or more times in the ARD period, quadriplegia with a score. You'll see what the score variance is: COPD or short of breath only when they're lying flat. There's 3 choices for short of breath on the MDS. If you're not an MDS coordinator, you would have known that, but only the one for lying flat will count there as it relates to that. IV fluid while or while not a resident in the center, if it happened during the ARD period. Respiratory therapy, 7 days, and then fever, and then one of the following: pneumonia, weight loss, qualifying feeding tube, which would mean that it's 51% or more of the calories, or 26 to 50% of the calories, and at least 501 or more cc's in a day. And that's not new. Special care, we look at special care high, then you'll see the condition services, and that looks for indicators of mood state disorder. Excuse me, that we got briefly a few minutes ago. We talked about PHQ-9, and that would be for the indicators of depression. If the answer is yes, it'll take the functional score, just like how it takes the ADL index score now, and it'll make a RUG rate, and you'll see that it'll be an HDE2 versus the 1. So indicators of mood state disorder will also gain more. Now, someone asked me, why does CMS give us more points if a person has indicators of mood state disorder, even though we may or may not be doing anything about it? It's the presumption of CMS that you've identified a person has a mood state disorder, that the center will be doing something about that to support that person, and that would be why. Now, when we look at special care low, we look at other conditions such as cerebral palsy. We look at multiple sclerosis, Parkinson's disease, things of that nature, just like we did before. And so it's going to look at that, and it's going to add the NFS score that it's going to look at. And it's also going to look at things like dialysis while a resident. That meaning going to dialysis center typically. Special care low is going to look at things like PU, stands for pressure ulcers, and you'll see stage 2 PU, and you'll look at that it has at least 2 treatments, and so you'll see stage 3 or stage 4, you might only have 1, as opposed to if it's a stage 2, you would have to have 2. Looks at venous and or arterial ulcers and related treatments, etc. A little reminder: pressure ulcer, venous ulcer, arterial ulcer, etc. Those are diagnoses, and only physicians or physician extenders in Florida can give a diagnosis. So again, we can't code something on the MDS if it's not in the clinical record during the ARD period. So if your wound care doctor only comes once a week, you may want to look at making sure that he or she is contacted. More often than not, the primary care physician does not want to add those diagnoses. So we want to make sure they'll say, oh no, refer that to the specialist. So we want to make sure. I understand that if we see an alteration in skin integrity over a bony prominence, that the stated guidelines in any manual that any one of us could read, whether you're a nurse or not, will tell you whether or not it's a pressure ulcer. But pressure ulcer is a diagnosis, so you want to make sure your nurses aren't calling something a pressure ulcer, or any other kind of ulcer for that matter, until you have the physician or the physician extender to say so. Same thing with special care low, as we look at conditions, indicators of mood state, and it's going to be whether or not yes or no, meaning whether or not it was present or not. Then it adds in the section GG functional score, and then it comes up with your new PDPM RUG score. Clinically complex looks at extensive services special care high with an ADL index score. You'll see that. And then it looks at pneumonia, hemiplegia, hemiparesis, surgical wounds, burns, chemotherapy while a resident, oxygen therapy, etc. So if we take that and put that into your chart here, you'll look again. Each one is always going to be impacted by indicators of mood state disorder, and you'll get a higher RUG rate if you have that. Now, it's interesting because some people always have their social worker do the indicators of mood state, but I was at a building recently and I really like this method, and I think I would subscribe to this myself. One person, there are 4 interviews on the MDS. There's the BIMS, the brief interview for mental status, there's the PHQ-9, there's the pain one, and there is for activities. And so it's interesting because in a couple of centers that I've recently visited, they decided to have only one person do all four because they're an interview. They're not clinical assessments. They're just an interview. I found in those particular buildings, now there's only been a few that have done it, so it's certainly not statistical in any way, but I found that they actually followed the MDS directions better. So in the MDS directions in Chapter 3, where you give the item by item review, for instance, it says that the PHQ-9 should be done at the latter end of the assessment reference date period. But for whatever reason, often I find the social worker does it at the beginning. And it stands to reason that indicators of mood state would probably be more pronounced after, more days are spent in the facility. The first day or two they get there, it's kind of a whirlwind. They were in the hospital, they come to your nursing home. Long story short, it seems like using the CMS directions will actually bear better financial outcome. So you may want to put on your follow-up list to find out, whoever's doing the PHQ-9, are they doing it as per the MDS directions? And every section of the MDS is in Chapter 3, and you'll find that there is a lot of really good information. One section is going to be called coding directions, and that's going to let you know. Okay? So again, looking at the nursing classification, you'll see the behavioral symptoms. I'm not going to read that to you because that's there. Reduced physical function, and again, if we're going to have if we're going to have an active restorative program, it has to be 6 out of the last 7 days, and it has to be 15 or more minutes as documented. Now, someone said to me the other day, do I have to have separately designated restorative nursing assistants to have a restorative program? And of course, the answer is no. How you decide to do it in your building is your methodology. I have found that there's more success when they have dedicated restorative programs, but it's certainly not a requirement, and there's a lot of ways to get that accomplished. You'll see on the reduced physical functions, it'll go with the restorative, it'll go look at the nursing category, and then the condition and service, and then whether or not they received it, and then how many, and then it'll look over at the section GG functional score that we've talked about previously, and then to the far right-hand side, of course, you'll see your rug. Let's look a little bit at the NTA process. Under PDPM, the comorbidity score is the result of a weighted count of a person's comorbidities rather than using a simple count of their comorbidities. So basically what that does, it ignores the differences in the relative costliness between the different comorbidities. So you're also looking at the most costly comorbidity, and you would ignore the effect of the patient having multiple in that case. So to achieve this weighted goal, you're going to look at each of the 50 possibilities under the PDPM, and it's going to be assigned a certain number of points between 1 and 8 based on its relative costliness. And I have a handout that I've attached in here for you to see what those are. And so you'll need, for instance, HIV AIDS will be higher because obviously that had that 18% add-on. So the resulting sum represents the patient's NTA comorbidity score, which is then used to classify the patient into a component classification group. So here's a table that's going to show you that information. So HIV up top, you'll see as the condition, you'll see the source where it came from, which would be on the SNF claim, it would be B20, and then you see the number of points on the far right-hand side. And I'm going to skip through because that's all that this is showing you the points. Okay, so the non-case mix is flat. It's not case mix adjusted. We already talked about that. So PT and OT day 20 drops 2% every 7 days. We've said that already. So there's your Medicare payment days, and then you see the adjustment factor for the NTA. You'll see after day 3, you'll see that it goes down to 1%. So if you kind of put it all together, you're going to look at PT and OT, and you're going to see the base rate for PT and OT and the CMI adjustment. And you could do the same thing as it rates then to speech therapy, as it does for nursing, as it does for the NTA, and then the non-case mix. So if you have, these are unadjusted base rates, so if PDPM has been implemented in fiscal year 2019, you'll be able to see the unadjusted federal rate per diem right now, and this is for rural. And you'll see what the PD per diem rate is for nursing, NTA, PT, OT, ST, and then you'll get your non-case mix set in there. Labor cost adjustments will also continue under PDPM. So here's an example. Mr. T had a hip replacement and he was sent to our facility. His case mix groups are as follows. And so if you want to move that example here, you can see days 1 through 3, it'd be $715.20. Days 4 to 20 would have went down to $565.35. And then the first example, the 2% further decline between day 21 and 27 drops in another approximately $4. Another example has a very medically complex person, and this person has multiple comorbidities, joint replacement, dysphagia, a mechanically altered diet, septicemia, and indicators of depression. And then, of course, their score for section GG is 12 plus. So we look at PT and OT case mix group. We look through speech, nursing, non-therapy, and the case mix flat. And that translates to this next slide where you can see where days 1 through 3 was $1,332.87, 4 through 20 was $825.54, and of course day 21 to 27 shows that next reduction. So some updated rules related to the IPA assessment. Under PDPM, effective October 1st, there are 3 SNF PPS assessments: the 5-day assessment, the interim payment assessment, and the PPS discharge assessment. The IPA is called an optional assessment. It's going to be based on the guidelines that you're going to find in significant change. Those are on pages chapter 2 of the MDS manual, starting on page 2-22 all the way through to 2-26. Now, it's optional because you don't have to do it, but to be honest, if you have a person that you're carrying a caseload on, just like right now in the reimbursable therapy minutes review, if you don't identify that the person's not using the same amount of RTMs, and then you don't do a corresponding COT or change of therapy, obviously if there's an audit, there's a problem. Well, it's going to be the same way here. So it would be wise for people to review significant change because that's going to be the process. So you can see here where it looks where the 5-day PPS schedule is still going to be done between day 1 and 8. And then we look at the interim payment assessment, and that's going to be done. Obviously, that's how you're going to change your rate. So if the person goes up and needs a higher amount of overall services, therapy included, then obviously if you don't do the interim payment rate, you're not going to get that increase. Correspondingly, if a person has a decline because they have a improvement, just like the MDS directions say, obviously that's going to be problematic as well. And then, of course, the PPS discharge assessment. So someone said, oh, we only are going to have 3 assessments. We don't need all those MDS coordinators. Not true. There's lots of things for the MDS coordinators to do, to include case mix, manage with them, and also to really look at the significant changes. So really that has not changed. Effective January 8th, you will have seen that the assessment will be used for transitioning Part A, patients from RUGS 4 to PDPM, and for those that were on Part A before that. The MDS form for the IPA has been unveiled. And that has been tweaked already since it's been unveiled. There is no transition period between RUGS 4 and PDPM, and that's the most important thing to know. September 30th ends RUGS 4, and October 1st begins PDPM. Obviously, there's going to be a process where we take people that are already in place, and we'll talk about that in a moment. To receive your PDPM HIP score, you're going to have to use for billing beginning October 1st. You're going to be required to complete an IPA with an ARD no later than October 7th for your SNF Part A patients. If you fail to do that, you will get the default rate. So that's going to be very important to do that. There is a presumption of coverage under PDPM. If the patient meets any of the following 4 PDPM-related criteria, the person should qualify for the presumption of coverage. 1, nursing groupers that classify into the categories we've reviewed. 2, looking at PT and OT groups. 3, looking at the designated speech therapy groups, and 4, looking at the NTA components comorbidity groups. The group and concurrent therapy, remember, limits to 25% combined, and so your validation reports, when you submit your MDS, it goes through the QIES ASAP system, as you may recall, and there's a validation report. Hopefully you have a system in place where you review the validation reports, perhaps in conjunction with your monthly QA. If you don't, you might want to think about that, because that's where they're going to put a little note to tell you if you have exceeded your 25% combined. And if you do, that will certainly raise the eyebrow of CMS, if you will. Most services provided are on an individual basis. However, there are times when group or concurrent therapy is beneficial for the patient. Currently, if you wrote that someone had 60 minutes of group services, then that would be reflected on the MDS. The software would bring that down to 15 minutes. Or now it's going to show an hour for PDPM. Same thing for concurrent. If you put an hour on, if you put 60 minutes, it would reflect under PPS as 30 minutes, but it will reflect as an hour for PDPM. So that'll be important to note. The interrupted stays, the payment calendar continues using the adjustment factor. So if the resident is discharged from the facility and then returns to the same facility within 3 midnights. Now, note same facility. If they go to another facility, it's going to be considered a new stay. So if the person goes more than 3 consecutive calendar days after discharge and maybe they go to a different SNF, that's going to be handled differently. The readmission source is irrelevant, doesn't matter where. The review of the MDS items will be the IPA and the OSA. There are new item sets that have been created, and I do not have a copy of that on this. We will actually add that to the FHCA website shortly. That will be just adding a copy of all those tools, and I know that's where they're going to keep updating them. Second, for states that rely on the RUGs 3 and 4 assessments scheduled for calculating case mix groups, and I know some of you are multi-state buildings, you'll be thinking about as it relates to Medicaid payments. I know we're in a different situation for our Medicaid payments. The optional assessment will be in place from October 1st through September 30th. The new MDS Section I, SNF primary diagnosis, will be to capture the patient's primary diagnosis, which is used to classify, and remember, into the PDPM clinical category. And so you'll see that additionally added to Section I, and this will allow for providers to report using the same ICD-10 code that the patient's primary SNF diagnosis is. New items for the MDS are continued to be added. So what is the main reason the person is being admitted to the facility? Which should be the question you're asking right now in your weekly pre-billing PPS meeting in terms of managing length of stay, et cetera. Why is the resident here? What are their obstacles? What do they need to be able to successfully discharge if they're leaving the center? So there'll be a coding for that, and it'll be a response that'll be a 1 through 13. We already mentioned about the surgical history and then importance of that, and I mentioned the new items, section J2100 to 5000, and those will be used to capture all those surgical and major issues that we talked about earlier, and you saw them. There was a sheet of those. New MDS items for section J, patient surgical history, and we've already talked about that, and that's where the importance of getting those history and physicals. And here's just another way to look at that, so I'm going to scroll through that. Those are all the same J codes that we referenced earlier. New MDS items, section O, discharge items. That'll be to capture the therapy delivered information over the course of the patient's entire Part A stay. So that's going to be important as it relates to current and group therapy as well. And all that will again be coded in section O where things of that nature are currently coded. Looking at the look back period for the entire PPS stay, providers will report by discipline and the mode of therapy, the amount of therapy in minutes. So even though you're not getting paid by minutes, you are still calculating the minutes. If the total amount of group and concurrent minutes combined comprises more than 25% of the total amount of therapy for the discipline, you will get a warning message. And again, that'll be in that validation report. So please make sure you have a system to evaluate your QIS ASAP system validation reports that are currently in place so that when this is added, it's not getting missed. The new MDS item section GG will be the interim performance. That'll be very important. And there's going to be a new column which will capture the interim performance of each individual resident. A way to start to prepare for that might be to look in the MDS manual in Chapter C. So after Chapter 6, we'll go into A, B, C, and so forth. In Chapter C is where the care area assessments live. On page C-24 is actually an ADL task assessment tool. For some reason, I don't see a lot of people using that. However, that would be a really nice way to have therapy and nursing working together to capture information. I think that would make them more effective in section GG as a consideration. Existing MDS items added to the PPS item sets are going to be noted, and they'll be added to the PPS as part of the PDPM implementation, which means they do not exist until October 1st. So even though there's systems and methods to do some evaluations of what you're billing now under PPS and how that would fare under PDPM, keep into consideration that there will be information that won't be included because it will not be there because it's not present. Now there's some information here about swing beds, but I don't understand that we have anybody with a critical access hospital swing bed on the telephone today based on the list I was provided, so I am going to go through that. If somebody has a question related to that, they're welcome to give me a call. So I want to just do a quick summary because time is drawing near. We're about 11:53, I see. Keeping in mind, PDPM per diem rate will be used upon the sum of those 6 individual components that we talked about at the beginning. 5 of those components are case mix adjusted, but the one is not related to room and board, etc. PT and OT, even though that is case mix adjusted, it's going to have that reduction after day 20, 2% every week until the person is discharged. The NTA component is going to have that adjustment factor for day 1, 2, and 3. It is at the 3.0, but after day 3, it's going to adjust down to 1.0 thereafter. PDPM proposes only the 5-day PPS and discharge assessment. However, we are well aware that we're going to have significant changes that we're going to have to capture in that, quote, optional assessment. And if we don't capture them, A, we'll probably lose monies when it goes up, and B, if we don't capture the changes as per the MDS manual for significant change and you get an audit, then you'll be asked to return money. So there really aren't just 2 assessments. So I want to thank you for spending time. I know an hour was a very brief period for this. You'll be more than welcome to send any questions you want in to Melanie at Florida Healthcare Association. She'll create a list and then we'll be happy to respond to any of them. And I would be remiss if I didn't mention my colleague Nation Shaw, who was part of putting this presentation together. Thank you again. I greatly appreciate your time today.
Great. Thank you so much, Robin, for that wonderful presentation. If you do have follow-up questions, you can certainly type them in that question box now or email me directly. You're more than welcome to do that. We will compile the questions and put them together for a response. If you submitted one, please know we will get your answer to you. I just want to give a very big thank you to our presenter, Robin Bleier, President of RB Health Partners, and a really big thank you to our sponsor, Medline Industries. And always, we thank you for attending today's webinar and for your work to provide center person care in Florida. So that will conclude our webinar for today. Everyone have a great day, have a great weekend, and we'll talk to you soon. Thanks.